Hello and welcome to the Super High Yield Anesthesia Podcast, the second edition. This is your host, Scott, the anesthesia resident. Thanks for tuning in to episode 19 of the Super High Yield Anesthesia Podcast, and today we'll continue our talks on OB anesthesia, and particularly we're going to do part 2 of management of high-risk parturients. And this particular episode, we're going to talk about obstetric hemorrhage, advanced maternal age, preterm delivery, and substance use. And I did a episode on obstetric hemorrhage back in the first podcast, the original Super High Yield Anesthesia. If you want like the super basic talk on these particular types of hemorrhages, I'll put in a link into the description if you want to listen to that. But then I think this one is going to build on top of that and give a little bit more information than I did in the previous one. So without further ado, let's go ahead and get started. So regarding obstetric hemorrhage, there's generally 4 categories of the types of hemorrhage. So there's hemorrhage due to abnormal tissue or placentation. There's hemorrhage due to abnormal tone or atony. Abnormal coagulation is the third one. And lastly, trauma. So things like uterine ruptures and C-sections. And then from there, it's you could kind of also break it into antepartum hemorrhage and postpartum. So first of all, let's go ahead and talk about antepartum hemorrhage. And the first one is abnormal tissue or placentation. We're going to talk about placenta previa, placenta accreta, and lastly, we're going to talk about placental eruption, or aka abruptio placentae. So regarding placenta previa, it's abnormal implantation, usually on the lower uterine segment. And regarding epidemiology, placenta previa, it occurs in about 0.4% of pregnancies. It leads to 0.9% of maternal mortality, and there's a 17 to 26% perinatal mortality. The risk factors for placental previa are things like smoking, advanced age, advanced maternal age, multiparity, multiple gestation, cocaine abuse, and prior C-section. So, an interesting thing about history of prior C-sections is there's an increased risk in a dose-dependent manner. So, for example, the more C-sections a patient has in the past, it means that they're going to have an increased risk of developing placenta previa. And actually, before we can kind of continue on talking about the different types of risk factors and whatnot for these various hemorrhaging conditions, one thing that I learned that kind of correlates, or it kind of ties in what you learn about these diseases and how you actually affect how you practice anesthesia, is if you know these patients have these risk factors. So, for example, they have a lot of C-sections in the past, or they have been pregnant quite a few times, or they have like a history of substance use, like smoking, cocaine, whatever. It increases the risk for these particular disease processes, and therefore it increases the risk for hemorrhage. So, that in mind, like when you're preparing for a case, let's say you're bringing back a patient for a C-section, you're thinking, okay, if these patients have these risk factors and if they have these diseases, chances are they're going to bleed, and they're going to bleed a lot. Because the thing about OB anesthesia is things can actually go south really quick. I had a case once where, patient's been pregnant like literally 10 times, had multiple C-sections, and throughout the case, she was doing fine. But then, like within the course of maybe 3 minutes, her MAPS went from 75 down to 35. And so, as you might assume, my sphincter tone kind of increased quite a bit during that case. So, what I should have done for that one is to have blood in a room. If I anticipated that about these risk factors, I would have had blood in a room. So in case things do go south, I have it immediately available to transfuse. Because when, at least in our institution, having blood brought up to the OB floor takes a little bit longer time. And sometimes that's not acceptable for the how quick these patients will tank. So again, when you're listening to me talking about these risk factors for different types of conditions that could cause obstetric hemorrhage, just think about how, if you're able to spot these risk factors and then using that to guide your clinical decision making and determining whether or not you need to have your hotline set up or have blood immediately available in a room. I hope that makes sense. Basically, use this to prepare for your case. Okay, so sorry for that rant, but I think that's a very important lesson that I learned the hard way, and hopefully you guys don't have to learn the hard way too, but experience is the best teacher, right? So, okay, going back to placenta previa. We talked about the risk factors for placenta previa. The presentation, which is very high yield for boards, is painless, bright red vaginal bleeding, usually after the 7th month of pregnancy. So the patient is in 3rd trimester, they suddenly have painless vaginal bleeding, that's bright red blood, then it clues you in that this is placenta previa. Versus the other type, placental eruption, which we'll talk about, is painful. But again, we'll get to that in just a moment. Okay, so anesthetic considerations for placenta previa. Again, these could bleed, so make sure you have type and cross, have IV access, large IV access, so ideally you have a large bore available, so 18s or higher, and you can volume resuscitate as needed. For these ones, try to do neuraxial if the patient is hemodynamically stable. Otherwise, you'll be doing general anesthesia. And if the bleeding is extremely severe, they may require emergency hysterectomy. So always be prepared to convert neuraxial to general. Okay, so that's placenta previa. Next part of antepartum hemorrhage is placenta accreta. So the risk factors for placenta accreta are placenta previa, prior C-sections, advanced maternal age, and fetus of the female gender. I actually don't know why it's female fetus increases the risk factor for this, but I guess it's one of those correlation things. But essentially, if you or the OB team suspects placenta accreta, or if it's known, usually the delivery is going to be planned for 36 to 37 weeks gestation via cesarean hysterectomy. But if fertility continues to be desired, there's other methods to help control the possibility of severe hemorrhage. And some of these include things like arterial embolization or ligation, uterine compression sutures, and methotrexate therapy. Okay, and anesthesia considerations for placenta accreta. Regarding pre-op, again, make sure you have the large bore IVs, because if you need to transfuse things, especially if you're calling it a massive transfusion protocol for these patients, you're going to need a large bore. Consider an A-line if the patient is hemodynamically unstable, type and cross and preparing red blood cells, PRBCs before the procedure. Ideally, if you have a very high suspicion for hemorrhage, you can have it in the room prior to starting a case. And lastly, of course, you can have your baseline lab so you can compare it to as the case goes on. Intraoperatively, again, neuraxial in the C-section is going to be the most preferred method, assuming the patient is stable. And if the patient starts to hemorrhage, the preferred strategy for transfusion is basically goal-directed. So if you have A-line, you can continue to draw labs, get an AVG, get other labs like TEGs or whatever to kind of figure out the patient's status and then transfuse accordingly. And one thing that you're going to try to do is prevent a decrease of fibrinogen below 2 grams per deciliter. And if for whatever reason you end up having to do a massive transfusion protocol for these patients, or MTP, it's going to be important to do hourly electrolyte checks, because remember, if you transfuse a lot of PRBCs that has citrate in it, so you can have things like hypocalcemia, and you're going to have to be able to replenish that, or else the patient's going to still remain hypotensive despite the volume resuscitation. So that's placenta accreta. And the last part of antepartum hemorrhage that we're going to talk about is ruptio placentae. otherwise known as placental eruption. And the definition for this is that it's a premature separation of normally implanted placenta after 20 weeks gestation. And regarding epidemiology, it occurs in 1% of deliveries. The maternal mortality rate is 1.8 to 11%, with a perinatal mortality of 50%. So as you can see, these are very high percentages of mortality in placental eruption, and therefore it's a pretty serious problem. Again, risk factors for placental eruption: smoking, trauma, cocaine abuse, multiple gestation, hypertension, preeclampsia, and PPROM, or premature rupture of membranes. And usually the presenting symptoms for placental eruption are things like uterine tenderness or hypertonus. There's going to be vaginal bleeding that's dark and often clotted. There's going to be a lot of pain associated with the placental eruption. A lot of times if you have like a board question that says patient was in a car wreck and then you have uterine tenderness and then lots of vaginal bleeding that's dark, then this is cluing you in on placental eruption. Okay, so generally speaking, they could actually lose a lot of blood prior to having any changes in vitals. So you can have if you have greater than 2 liters of blood loss, then you'll see blood pressure and pulse rate changes. So you might have to be playing catch up even though your vitals are pretty much the same. And lastly, regarding fetal issues in placental eruption, there's going to be increased fetal movement with acute hypoxia. You could have fetal bradycardia. And if there's placental separation that's greater than 50%, the stillbirth is the likeliest of outcomes. Okay, complications due to placental eruptions includes things like, I'm going to butcher this name, but cuvular uterus, which is the blood that dissects between the myometrial fibers. You could have things like renal failure, DIC, and Sheehan syndrome, which is basically hemorrhage that gets to the point where it causes pituitary apoplexy. Basically, you're just draining the blood from pituitary gland, and then you have issues with lactation because you're not producing prolactate and things like that. That's the usual presentation. And also thyroid stuff is going to be messed up too. Okay, so those are complications of placental eruption. The management for placental eruption: if the patient is hemodynamically stable and they have normal coagulation labs and there's no fetal distress, an epidural is actually okay for vaginal delivery. But if there's any issues, if the patient's unstable, then you're going to have to do an emergency C-section. Regional anesthesia might not be a good idea due to the hemodynamic instability. Because remember, if you do, say, a spinal, you're going to drop their maps pretty quick. So doing general anesthesia is going to be the most appropriate decision. And this kind of goes again, if, say, you start off in neuraxial, but then they start to massively hemorrhage, then you're going to have to convert to general anesthesia. And this is a general concept. Other than that, it's going to be similar management as Previa. You're going to do goal-directed transfusion. So good idea to get an arterial line, draw labs, and just transfuse accordingly. And especially for this, again, this is going to be like the common theme. Make sure you have blood products available before the procedure. Have the type and cross in, have the prepare PRVC order in, and then have your OR staff bring that cooler of blood to the OR. Because I can't tell you the amount of times where I had an emergent situation that requires transfusion, but it took like 15, 20 minutes to get the blood actually in the OR. So that is a lesson I learned the hard way, and hopefully I kind of hammered into you to try to avoid my mistakes. Okay, so that's all the antepartum hemorrhage that we're going to talk about. And now we're going to move on to postpartum hemorrhage. So postpartum hemorrhage is defined as blood loss that's greater than 500 cc's after vaginal delivery, or if blood loss is greater than 1,000 cc's after a C-section. And generally, the most common causes of postpartum hemorrhage is going to be uterine atony and a retained placenta. So for uterine atony, the general causes of this or I guess the general risk factors of uterine anony is going to be things like multiple gestations, labor induction or augmentation, C-section, polyhydramnios, chorioamnionitis, hypertensive disorders, retained products, and antepartum hemorrhage. And the treatment for this is going to be aggressive uterotonic therapy for anony, and which we'll discuss next, and intrauterine balloon tamponade if the bleeding is still not controlled. So that's uterine anony, the most common cause of postpartum hemorrhage. Then the second cause of postpartum hemorrhage I would talk about is retained placenta, and this occurs in 1% of all vaginal deliveries. And the thing is, if the patient has an epidural, you can continue the epidural for the procedure to remove the retained placenta. If not, you can have spinal anesthesia or low-dose ketamine to help with that. And you can also use nitroglycerin for uterine relaxation if the OB team requires it. And this is done using 40 mics boluses. Okay, so regarding the different uterotonic therapies, I talked about this in the original podcast, but we'll kind of go over it again here just to kind of hammer it home. The most common uterotonic therapy that you'll be using, and usually is like the first line for uterine anony, is oxytocin, or the brand name or trade name is Pitocin. So they say something like, oh yeah, start the pit, then that's what they're saying, referring to the oxytocin. Generally, the dose for this is going to be 20 to 40 units in a 1 liter bag of LR, and you run it in as a drip. The major side effects for this is going to be hypotension, decreased blood pressure due to decreased vascular tone in the small and peripheral arteries, and you can also have tachycardia as a reflex tachycardia. And generally, you start say for example you're doing a C-section, and you start the oxytocin. I'm trying to stick to generic names here. Immediately after the baby is out of the uterus. So my cue for starting, or at least hooking up the oxytocin, is when the OB team calls out uterine, which usually means they're doing a uterine incision. So from there, I hook up my oxytocin to the second IV. Usually I don't start it, or I don't even hook it up until I hear uterine, just to make sure that we don't accidentally transfuse it. So again, once I hear uterine, I hook up the oxytocin, and once I look over the drape and see that the baby's out, now I start it, and I announce it to the OB team so they know that it's been started. And it is gonna kind of depend on your attending or whatever you want to do, but what I do is once I start the Pitocin, I actually use a 20cc syringe and then just bolus about 100cc of the oxytocin, just to make sure that we have the oxytocin like in the system, being able to help the vasoconstriction and improve the uterine tone. So to basically stay ahead of the potential blood loss. And of course, like I mentioned earlier, the side effects is going to be hypotension. So in order to compensate for that, I usually have a phenylephrine drip running already after starting after I place the spinal. So when I start to bolus the oxytocin, I increase the phenylephrine a little bit to kind of compensate for the hypotension due to the oxytocin. I hope that makes sense. So basically, once they're at uterine, I connect the oxytocin, baby's out, I start the Pitocin, I bolus 100 cc's, and I increase the phenylephrine drip to compensate for that, and then I titrate that down. And usually that works pretty well. Okay, so that's oxytocin. Next is ergot alkaloids. The generic one that we use is methylargonovine, or the trade name is Methergin. And the dose is going to be 0.2 milligrams IM. So this is very important that you do intramuscular and not IV. And you could give this Q2 to 4 hours as needed. And the side effects for ergot alkaloids, things like methylargonovine, are hypertension and vasoconstriction, coronary vasospasms and bronchospasms. But the main thing that you'll get pimped on and is high yield for boards is ergot alkaloids, things like methylorgonavine, are contraindicated in patients with severe hypertension, preeclampsia, or eclampsia because you're just going to exacerbate the already high blood pressure. Okay, so that's ergot alkaloids. Next is carboprose. The trade name is going to be Hemabate. The dose for this is 0.25 milligrams IM. Again, these ones are going to be IM. Q15 to 60 minutes as needed. The side effects for carboprose is going to be increased cardiac output, possible increased pulmonary vascular resistance, bronchospasms, as well as nausea. And the high yield point for carboprose, or aka Hemabate, is that it's contraindicated in asthma and pulmonary hypertension because it will exacerbate the asthma and then make the pulmonary hypertension worse. The asthma, the important thing is it could cause the bronchospasm. Okay, next is misoprostol, and this one, the dose is 800 to 1,000 mics per rectal. So this one's not used very often. I haven't used it. I want to avoid doing that. So side effects from misoprostol is things like fever and nausea. And lastly, you can use something called dinoprostone. This one is 20 milligrams PO, Q2 hours, and the side effects for dinoprostone is going to be hypotension and nausea. So so far, I've only ever used the first three. So oxytocin, the ergot alkaloids or methylorgonavine, as well as carboprose. But I have yet to use things like misoprostol and dinoprostone. All right, so that kind of concludes not the episode, but obstetric hemorrhage. So that's like the major part of this episode. Next, we're going to talk about advanced maternal age. So basically, the older the parturient is, there's going to be associated with a few adverse effects. Things like gestational diabetes, preeclampsia, placental eruptions, the increased likelihood of cesarean delivery, and as well as hypertension. So if the patient has at baseline chronic hypertension, they're at greater risk for superimposed preeclampsia, increased risk for a C-section, delivery before 37 weeks gestation. They have increased risk factors for placental eruption, CHF, pulmonary edema, hypertensive encephalopathy. So basically, if they have hypertension going in advanced maternal age parturient, bad things can go badder. Don't worry, English good. All right. In general, advanced maternal age parturients have more comorbidities. So they might have, in addition to high blood pressure or diabetes, they could have some other kidney issues, so on and so forth. So then that requires a more thorough workup. Other than that, other types of issues that could occur in advanced maternal age parturients is there's an increased incidence of things like miscarriage, congenital anomalies, preterm delivery, low birth rate, intrauterine or neonatal death. So basically, the older the parturient is, then the more comorbidities that they have, and you have to take those things into account when preparing your anesthetic plan to take care of these patients. Okay, the next section is going to be preterm delivery, and the definition for preterm delivery is going to be anything before 37 weeks of gestation. Epidemiology-wise, it's about 8 to 10% of all births and about 80% of neonatal deaths. Fun fact about myself, I was one of these preemies. I was born, I think, 35 weeks gestation via C-section. So yeah, woohoo, preemie. Anyways, regarding preterm deliveries, there's possible issues for baby as well. So that increases the risk for things like respiratory, neonatal respiratory distress syndrome, intracranial hemorrhage, hypoglycemia, hypocalcemia, and hyperbilirubinemia. So different things for a baby. And in order to try to optimize the birth for these preemies, the ideal thing is to delay birth to administer glucocorticoids, which pretty much helps with surfactant development to help with fetal lung maturity so their lungs don't collapse on themselves on birth. And the way you can delay birth is using things like tocolytics. Some types of tocolytics include things like magnesium, which can also help reduce the risk of cerebral palsy if given before 30 to 33 weeks of gestation. You can use prostaglandin inhibitors, beta sympathomimetics, so like those beta 2 agonists, things like terbutaline. And lastly, you can use sorts of calcium channel blockers. And the interesting thing that is related to us on the anesthesia side is the pharmacokinetics and dynamics in the preterm newborn. So things that we have to keep in mind when delivering medications. So certain characteristics for the preterm newborn, there's less protein in these preemies for protein binding. There's higher levels of bilirubin, so it could compete with drug binding. There's increased effect on CNS due to poorly developed blood-brain barrier. There's more total body weight compared to fat for these preemies. And lastly, there's a decreased ability to metabolize and excrete drugs. So basically, on all these things into consideration, you'll require less drug to have an effect on these preemies. And then, especially if you're using drugs that normally cross you have drugs that could possibly cross the blood-brain barrier due to its not being fully developed. But the good thing, though, is that this mainly is applicable to drugs that have that are highly protein bound, and most anesthetics are usually low to moderate protein binding. So it's not too big of an issue for us, but it's something to keep in mind when you're caring for these patients. Again, going on to anesthesia considerations, the techniques and drug choice is actually less important than trying to prevent asphyxia and trauma to the preemie, because again, most of our drugs are low to moderate protein binding, so their differences in pharmacokinetics is not as bad. So when you're doing vaginal delivery, neuroaxial procedures like epidurals is going to be a good idea for these preemies, premature babies. Otherwise, if it's like a breech presentation, you're usually going to do C-section. But if for whatever reason they try to do vaginal delivery, you can use nitroglycerin for relaxation if the head gets stuck. Okay, so we're moving on to the last section of this particular episode. And this is going to be the substance use and its effects on the pregnant patient. This is actually super important for people like me who works at a county hospital. So we, as a safety net hospital, we get a lot of these patients that come in with prior meth use throughout the pregnancy, or some sort of other substance use that's not quite ideal for the pregnant patient. So knowing the effects of these different drugs is going to be very important on your management of these patients. So first, let's talk about tobacco. And this is going to be one of the most common used drugs that you'll encounter during patients who are pregnant. Complications for pregnant patients that uses tobacco are things like miscarriages, intrauterine growth restriction, premature rupture of membranes, placenta previa, placental abruption. So again, if you have a patient with a smoking history, you're concerned for possible increased bleeding, right? So again, trying to hammer this into you guys. If you have any suspicion from history and physical that they have risk factors for bleeding, make sure you have the type and cross, make sure you have prepared blood orders, and if you're super concerned, definitely have the blood in the room prior to doing a C-section or whatever. Okay, so smoking increases the risk for placental previa and placental eruption. Also increases the risk for preterm deliveries, impaired newborn respiratory function, and lastly, SIDS, so sudden infant death syndrome. The maternal complications for tobacco use are things like bronchitis, pneumonia, and asthma. Other effects for tobacco use is nicotine. The nicotine that's contained in tobacco increases vasoconstriction, and that decreases the placental blood flow and O2 delivery. But you would think that this would make the preeclampsia worse, but it's actually kind of protective for preeclampsia, which is very surprising. It's like how smoking is also protective for UCs, like ulcerative colitis. But as with UC, you're not going to encourage your patients to start smoking to prevent preeclampsia. That's just not how we do it. So, so the other risk for smoking like outweighs the benefit of trying to make them smoke. Okay, so that's tobacco use. Next is alcohol. So the maternal effects of alcohol, especially if they have a significant history of it, things like liver disease, coagulopathy, especially if they have like an alcoholic cirrhosis picture. They have possibly developed cardiomyopathy, esophageal varices. They have increased risk for aspiration. There'll be possible changes to drug metabolism. And one of the big life-threatening things is going to be alcohol withdrawal. And usually the window for the most dangerous periods is going to be 6 to 48 hours of abstinence. And this can occur intrapartum and or postpartum. And symptoms, things like nausea, vomiting, hypertension, tachycardia, dysrhythmia, cardiac failure, and you can develop things like delirium tremens when you present with things like seizures. Okay, so if you have patients like this, I honestly have to look it up again, but I'm assuming having some sort of seawall protocol for these patients on the floor would be beneficial to prevent these sorts of potential disastrous effects due to alcohol withdrawal. Okay, so fetal effects on due to alcohol, things like fetal alcohol syndrome, neurobehavioral deficits, and intrauterine growth restriction. Next, opioids. Possible maternal comorbidities with opioids, especially with IV drug use, things like septic thrombophlebitis, HIV, and endocarditis. Other effects of opioids could include things like possible preeclampsia and third trimester bleeding, and anesthesia considerations for their Parturient on opioids or on some sort of narcotic is to try to continue the opioid actually throughout labor and postpartum period to avoid withdrawal symptoms. But it's usually stable if the patient is on methadone. Neuroaxial techniques is okay for these patients, but the important thing is to keep a close eye on the neonates, have close observation for them for possible neonatal abstinence syndrome. Okay, next drug is marijuana. And the interesting thing is THC actually easily crosses the placenta, so babies can get super high, super baked. And it's associated with preterm labor and intrauterine growth restriction. The maternal comorbidities for marijuana are things like respiratory issues, so like things like bronchitis, emphysema. So especially if you have to intubate and the patient to do GA, be aware that they could have some sort of respiratory issues. And if the patient comes in with acute intoxication of marijuana, they could have cardiovascular depression at a moderate dose, and even myocardial depression at super high doses. Next, you guys are almost there. It's going to be cocaine. The acute ingestion of cocaine usually presents as with symptoms like euphoria, tachycardia, hypertension, and in severe cases, seizure, coma, myocardial infarctions, pulmonary edema, and possible subarachnoid hemorrhage. And there's different effects based on when the mother utilized cocaine and in the different stages of their pregnancy. So in the first trimester, if they use cocaine, then it's possible that the baby will develop congenital abnormalities. And if they use the mother used it in the second and third trimester, they could possibly have premature labor, intrauterine growth restriction, and then possible uroplacental insufficiency. And in general, the treatment is going to be supportive. So basically, try to avoid a pure beta blocker, because if you use beta blocker, you can have unopposed alpha, and then you have severe hypertension. And I could be wrong. I'm saying this on top of my head, but then the common treatment for acute intoxication for cocaine is actually going to be benzodiazepines, so things like Versed. Okay. Regarding anesthetic considerations, if you're doing general anesthesia, be careful of the uncontrolled hypertension, tachycardia, and dysrhythmia. Especially avoid beta blockers, as we kind of talked about. If you decide to do neuroaxial, systemic toxicity may be additive, since cocaine is actually a local anesthetic. Especially if you're using an amide local anesthetic for the epidural or things like that. If you're using esters, it competes with cocaine for metabolism. So both of them will have decreased metabolism. So then you can have more of those two in the system. And again, be wary of profound hypotension for chronic users. And other than the uncontrolled hypertension that we talked about, other anesthetic considerations are things like ephedrine resistance. And acute intake increases the MAC of the volatile gases. But in chronic users, they have actually a decrease in MAC so they require less anesthetic dosages. And another thing for chronic users is that they actually might present with thrombocytopenia. Okay, the last drug we are going to talk about today is amphetamines, and this is actually the county favorite of everyone. Everyone seems to be on meth in our hospital. But generally for methamphetamines and amphetamines in general, the route is usually oral or IV for meth, or smoked as crystal meth. The mechanism for amphetamines is a non-catecholamine sympathomimetic, and essentially you can have a large increase in norepinephrine. And as you might suggest, or might guess, they're going to present with things like hypertension, tachycardia, dysrhythmia, dilated pupils, hyperpyrexia, proteinuria, agitation, confusion, and seizures. So basically, if you think sympathetic stuff, that's basically what they're going to have. Effects on fetus, basically the fetal anomalies and low birth rate. If the the Parturient takes it early on, and it's possible for things like placental abruption if they take it later on into pregnancy. And regarding anesthetic considerations, pretty much the same deal as cocaine. So again, try to avoid, be aware for the hypertension and increased sympathomimetic effects, and avoid things like pure beta blockers because you have unopposed alpha. Okay, that's it. You made it through what was a longer episode than I expected. But again, if you somehow made it to the end, thank you for listening. I really appreciate your time. Hope you learned a lot. If you have the time, I would appreciate it if you take the post survey with the link in the description. This way I can kind of figure out if you're actually learning anything from this podcast, and if you have any particular suggestions on improvement or criticisms, I would love to hear it. And the fun fact I have for you today is from thefactsite.com, and it's crows often hold grudges against specific people. So apparently crows are good at recognizing people's faces and are able to actually remember them for a very long time. And it's interesting because whether they are able to associate that person with either negative or positive memory. So if you're nice to the crow, then they'll remember that. But if you're a huge douchebag, they'll remember that too. So be careful of crows. Be nice to them, or else, I don't know, they'll exact their vengeance on you one way or another. Okay, so that's all I have for you today. Thank you for listening. This is Scott, the anesthesia resident, and I look forward to seeing you in the next episode.